Auditory evoked potentials such as ABR, MLR, and ALR are essential tools in evaluating the auditory system. They differ in latency, neural generators, clinical use, and more. Let's dive into their comparison to understand their specific applications and limitations. ABR has the shortest latency range of 1 to 10 milliseconds, reflecting brainstem activity. MLR has a latency of 10 to 50 milliseconds, representing thalamus and early auditory cortex activity. ALR has the longest latency, 50 to 300 milliseconds, generated by higher cortical structures. In terms of neural generators, ABR originates from brainstem structures like the cochlear nucleus. MLR comes from the thalamus and early auditory cortex, while ALR involves the auditory cortex and prefrontal areas, reflecting cognitive processes. Clinical applications also vary. ABR is used for hearing threshold estimation and auditory neuropathy diagnosis. MLR evaluates thalamocortical pathways and central auditory processing. ALR assesses cognitive functions, auditory processing disorders, and neuropsychiatric conditions. Stimulus and electrode placement differ as well. ABR uses clicks or tone bursts with mastoid electrode placement. MLR uses similar stimuli, but needs central electrode placement. ALR utilizes complex stimuli like speech with frontal and parietal electrode placements. Regarding noise resistance and sleep effects, ABR is highly resistant and minimally affected by sleep or anesthesia. MLR has moderate resistance and may be suppressed in sedation. ALR is most susceptible to artifacts and requires alertness for accurate results. Finally, sensitivity to pathology varies. ABR detects brainstem disorders. MLR identifies central auditory dysfunction, while ALR reflects cortical and cognitive impairments like ADHD. In summary, ABR, MLR, and ALR serve distinct roles in auditory and cognitive evaluation, helping clinicians tailor their use to specific needs.